Good evening. Welcome back. Tonight's Ask Me Anything is going to be somewhat of my update from the ACC conference, the American College of Cardiology event that was just recently held in New Orleans. I don't attend every year, but I always like to go to get up to date on what's new. Lots of interesting things for valve disease and how they treat heart attacks, but my job is to keep you away from the cath lab best I can. So that's what my practice of polycardiology does, is we're not proactive, we're not reactive, we're not waiting for you to have symptoms. So now there's a couple questions about what I learned. I'll talk about that in a moment. For those that are new, welcome. I'm Dr. Twyman, board certified cardiologist. My focus is on helping people find subclinical atherosclerosis and helping them reduce the risk of having a heart attack or stroke. Do that by optimizing vascular health, by looking at endothelial function, looking for oxidative stress and inflammation with lab work, using genetic panels when necessary, and treating lipoproteins, using a more novel approach than statins for all. So we'll jump into the questions, and if you have one that wasn't submitted ahead of time, drop it in the comments and happy to answer for you. So the first question tonight is about the Zona Plus isometric hand grip device to lower blood pressure. It's a very interesting device. I have one. I do recommend it to patients. Isometric exercises can decrease blood pressure, generally somewhere, I believe, in the neighborhood of like 5 to 6 millimeters of mercury on the top number. They discovered this in fighter pilots. There was a flight doc that realized that the pilots had lower blood pressure than expected. They thought they'd have high from the stress of flying, but with them holding the joystick at very high forces, that actually lowered their blood pressure. So that's how he designed the Zona Plus, to kind of mimic a fighter pilot's joystick. So it's a device that you give maximal grip pressure, hold it, release, switch to the other arm, and I believe it, do it at least 2 rounds on each side. So it takes a few minutes a day to do. Is something where if patients are wanting to try to do lifestyle interventions before considering medications for blood pressure, I recommend that they consider that. Question, can water in the ankles, legs have something to do with the weak heart? How to reduce the water? Yes, if this is edema, it is possibly related to an issue with the heart. The heart is a device that should pump and relax. So you may have systolic heart failure where the ejection fraction is low, or you may have diastolic dysfunction where the heart is stiff and doesn't relax well. But there's other reasons why the ankles can swell, including venous insufficiency, where the veins don't pump the blood effectively back up to the heart. It can be due to issues with the kidneys or the livers. You can look at that on the blood work. And it can be due to certain medications, particularly the calcium channel blockers, such as amlodipine. So it's not always related to the heart. It does take a good history and a physical exam, and usually can figure it out. How to reduce it? Ideally, remove the root cause that's causing it. But if you can't figure that part out, you can use compression stockings and also use diuretics or water pills to clear some of the fluid. Question, are there any risks associated with the GLPs increasing the resting heart rate? Generally, no. It may increase the resting heart rate a couple points, but at the ACC conference, there's a lot of interesting reports on the GLPs, particularly for patients that aren't diabetic or just overweight with BMIs over 27, how it decreases major adverse cardiovascular endpoints, meaning the things patients care about, less heart attacks, strokes, and dying. So the maybe slight increase in heart rate is not transferring to having increased cardiovascular events. It's the opposite. You have less cardiac events. The question, can I discuss the relationship between ApoE and high LDL for heart and Alzheimer's? So apolipoprotein E is something that is under genetic control. It helps shuttle cholesterol in the brain. You have 2 ApoE alleles. You have an ApoE 2, 3, or 4. So there's 6 possibilities. So you can be an ApoE 2, 3, 3, 4, or 4. You get 1 copy from mom, 1 copy from dad. The patients with ApoE4 alleles tend to have higher LDLs and do have a statistically higher risk of Alzheimer's, mainly because of the way cholesterol is transported in the brain. From a blood standpoint, why LDL is higher is often because the ApoEs have an effect on the LDL receptors and how the body clears cholesterol from the circulation. The ApoE4s, I don't tell them that they cannot take statins, but tend to have more side effects if you use high-dose statins. So usually recommend starting with low dose or adding ezetimibe early on if you can't get people to goal, based off whatever their vascular risk is. But the ApoE4s definitely would look at their insulin-resistant markers, make sure they're optimizing their sleep best they can and keeping inflammation low to really reduce the risk of developing Alzheimer's. And DHA from seafood is extremely important as well. If you look at the blood work, generally want a DHA level over 100 in patients who have an ApoE4 allele. And the question, what do I think about the new guidelines for statin use? The guidelines came out about 2 weeks ago. I've looked at them. Haven't read it in depth. It was 130 pages long, but have heard some conference talks about it, and then using Notebook LM to summarize it, create some infographics, and I'll be sharing those in my school community if people are interested in seeing that. But it is one of those things where I tell patients statins are tools, and I think you'd be myopic to only look at an LDL cholesterol to predict risk. So you can use the new Prevent calculator. Do I use it often? No, because I think it's more useful to look at total plaque volume. So if you're at high risk, look for plaque and treat the plaque. Cholesterol is let's say necessary for plaque, but not sufficient to develop it. So if you have plaque in the arteries, statins are one of the tools you can use to stabilize that plaque. Not everybody tolerates it, and I understand that. And I attended a lecture yesterday that was about, can cholesterol be too low and what are the potential side effects for statins? And there wasn't anything I, didn't already know, but it's good to hear from other people's frontline kind of issues that they have sometimes utilizing these tools. And muscle symptoms generally are the most common side effect, muscle pain or weakness. But I know that the new guidelines are pushing things down to maybe 30 years old. But I would say that would be more for people who have, strong family histories, have other risk factors such as high lipoprotein A, they're diabetic, maybe they still smoke, maybe they have uncontrolled blood pressure. That's when you would consider throwing the kitchen sink at people to lower the vascular risk earlier than later. You don't want to wait till they have a heart attack in their 50s and 60s to start treating those people. But I don't believe that statin should be utilized, blanketly to everybody. It's really needs to be nuanced. What are you trying to do with it? What dose is going to work for the person? And if patients can't tolerate statins or ultimately likely they prefer not to use them, use a different tool. There's multiple tools that have outcome data. And then tell us about the ACC meeting. Well, I'll do it briefly here, but my school community, I'll talk about it in more depth with them at the next AMA. The ACC is, a very large conference that's held yearly. Tens of thousands of cardiologists attend and ancillary providers. The expo hall is, probably 3 football fields long. The, new devices, gear, medication, treatments. So learned a lot more about different AI EKG devices, AI CT coronary angio analysis platforms. Went to some of the topics on preventive cardiology. Their analogy is it's always good to hear other people talk about it, but they talk about preventive cardiology as shutting out the faucet instead of mopping up the floor. So why wait for people to have severe vascular disease before treating it? There's better tools than ever for controlling blood pressure and lipids if you need to use pharmaceutical interventions. Understand some people are hesitant to use medicines at times, but lifestyle is always recommended. Always try to optimize your nutrition, your exercise, your stress management, your sleep. But if after 3 to 6 months your blood pressure is not ideally less than 120 over 80, the guidelines say 130 over 80 is the goal, but optimal is 120 over 80. Then consider pharmaceutical intervention if the person's at high risk of, cardiac events. You don't want to have a long-standing history of high blood pressure. It's a silent killer for a reason. It increases the risk of dementia, stroke, heart disease, kidney disease, heart failure. So high blood pressure is something that is the most modifiable risk factor. Now, I know a lot of people get, let's just say, tribalistic about lipids, but blood pressure should not be controversial. You have to control blood pressure if you want to have optimal vascular health. So that was one of the topics I listened to. There's many topics talking about the GLPs, particularly for patients that are not diabetic. It's interesting, how it helps lower inflammation, how it may help the endothelial lining of the artery. So it's protective of the arteries, irrespective of what it's doing for weight loss. One of the most interesting lectures I heard was listening about visceral fat on the outside of the heart called epicardial adipose tissue, or EAT. The fat on the outside of the heart, can be saturated, polyunsaturated, or monounsaturated, and the saturated fat tends to be more pro-inflammatory to the heart. But what's interesting is that the fat cells all over the heart have GLP receptors. So it's suspected that people who use GLP antagonists may be decreasing that EAT, and that may help lower vascular disease in the future. Still, let's just say experimental, not for prime time. That's just a theory. Makes plausible sense. So they'll probably be doing studies about that. But the benefits of GLPs in the right candidates, it's getting more interesting, particularly, people who have a lot of evidence of insulin resistance. Now, the question will be for people who are not insulin resistant, are not overweight, and while we know BMI is not the best measurement of your, metabolic health, if your BMI is below 27, these aren't guideline approved drugs for those people, but doesn't mean they might not work for some people. So, not saying avoid them at all costs, like maybe some people said in the past, but you have to still focus on optimizing your skeletal muscle health. These drugs are not risk-free. You can't eat junk, not exercise. You still have to do the things that your body requires. So focus on getting resistance training at least twice a week, optimizing your protein intake. Generally still will recommend at least 100 grams of protein a day to maintain, but optimally it's a gram per pound of your ideal body weight was what you really should be shooting for. And then the particular question you have, is there possible new methods to strengthen the heart? There are other drugs that are starting to come out for patients with hypertrophic cardiomyopathy, for amyloid heart disease, and the big push for the patients for heart failure is using the goal-directed medicines sooner than later. So, getting on an ACE inhibitor, beta blocker, MRA, and mineralocorticoid receptor antagonist. I always mess it up. It's easier to just call me an MRA, basically spironolactone, and then SGLT2 inhibitor. That's going to be the cocktail for anybody who's got a weak heart. But what's interesting is that the patients who have a weak heart from diastolic dysfunction, where they have normal ejection fraction, there's a new thought that may be due to more adipokines. So it may be due to this fat on the outside of the heart that is causing the diastolic dysfunction. And these are the patients that maybe the GLPs are going to be more beneficial for if you have diastolic dysfunction. And then a question got added. Blood pressure of 166/88. Thoughts on the cause and how to lower naturally are possible. So that is stage 2 hypertension. That is something that if it doesn't come down with lifestyle interventions, you're going to want to consider medications to reduce the risk of dementia, heart disease, stroke, kidney failure, heart failure. Optimal blood pressure is 120/80. Causes, hard to know, but without more information in history, but there's generally some component of endothelial dysfunction where they don't have optimal nitric oxide. Inflammation is a big driver in many people. Insulin resistance is one of the largest drivers. Uncontrolled sleep apnea. There's hundreds of potential causes, and with a good history, physical exam, and lab work, you usually can figure out the treatment. Best natural approaches: make sure you're sleeping optimally 7 to 8 hours. Stress is well managed. We use biofeedback, meditation. You can use heart math to help with cardiac coherence. Somebody previously asked about the Zona Plus device that can help. Then would also consider things like optimizing your infrared exposure. So sauna use potentially helps. So lots of things that may help, but if the blood pressure at home is consistently in that range, you need to work with somebody to help get it back down. All right. All right, so somebody says, what if your blood pressure goes high and then tanks regularly? So this will depend a little bit if people's on medications that are having this effect, or if this is just on their own with no medications. But what I would recommend is a 24-hour ambulatory blood pressure monitor to see what your blood pressure load is throughout the day, what times of days that these low blood pressures are occurring, what is the blood pressure overnight, what is your dipping status, is the blood pressure effectively dropping while you sleep, And then that may guide, if you're on medications, what time of day to take medications. And if you're not on medications, this might help pick up, do you have something like pheochromocytoma where you're increasing certain hormones that really spike the blood pressure. All right. So I think those are all the pre-submitted questions tonight. For those that are joining, I did say that I just recently got back from New Orleans. I was at the American College of Cardiology meeting. Big update every year. The big takeaways are, test don't guess. Basically, the lipid guidelines came out 2-3 weeks ago. I use them, but I do more advanced testing than the guidelines. So, it's a starting point, but big takeaway is that plaque matters. What's in your blood is important, but what is the plaque burden that you have? If you have plaque in your carotid arteries or your coronary arteries, and you're younger, you're going to want to be treated. Now, most cardiologists are really used to taking care of people for secondary prevention. People are coming in with symptoms. That's how most cardiologists pick up new patients. So if you're not in that category, which there's not a lot of debate on, those people benefit from intensive pharmaceutical interventions. So if you're more what's considered primary prevention, then this is sometimes where you got to be more nuanced. But there is a concept of something called primordial prevention, meaning you don't have any plaque in your arteries. How do we get to that level? That really has to start in somebody's probably teens or 20s. So focusing on basic 6, keep blood pressure down, don't smoke, keep weight controlled, control the lipoproteins, eat a reasonable diet. Most time a Mediterranean type template is usually recommended, but there's other templates of nutrition that can work for some people. Be physically active, at least 150 minutes a week. Those are kind of the basics, and they always will be. I always think about the conference as something where they're showing us the greatest and whiz-bang type of technologies, but a lot of times these technologies are for bringing people back from the brink of death. It's amazing that we have these things, but the goal is not to try to need these things. So if you're ever interested in learning how more, that we think about really reducing the risk of heart attack and stroke and not just treating them, then keep following me on here. Every Monday night we do these IG Lives. Look for me on, basically almost any podcast platform. I have at least 80 podcasts out there. I got a couple that are in the pipeline that should come out in the next couple of weeks. And if you're wanting more in-depth education, that's where my school community is, where I drop a lot of this nuggets of data. So my school community is in the link in my bio, but it's drtwyman.com/school. Every month I do a long form AMA there. People can come on live and ask me questions. And then I'm usually kind of sharing things that I'm learning along the way. So I recorded all the lectures I intended to using AI to transcribe them, make summaries, and I'll be sharing those in the school community. There's a 7-day free trial. People are interested in checking it out. No obligation to stay. But if it's something benefits you there, hang out with us. This is where we're going to learn this stuff together and continue to work to become heart attack proof. So hope you guys have a great week, and I'll see you next Monday, 6 p.m. Central Time.